Back with another session here. In this video, I'll be talking about the concepts of a structure of local anesthesia. We already spoke about the effect of the local anesthesia on the different parts. We already spoke about the types of nerves in the previous video. In this session, I'll be talking about the concepts of the structure of the local anesthesia, and I'll be dealing about the part 1 of pharmacokinetics. So now let us start with the first thing, that is local anesthetics. The name itself is telling local means at that point, right? Local area, anesthetic in the sense these are useful, right, for that only that particular area, right? And these local anesthesia are anesthesia, they affect a restricted area of the body, and these local anesthesia are of two groups, right? We are going to deal them under two things. One is amino esters and next is amino amides. So let's see what's written in amino esters. Under the amino esters you have got cocaine and the procaine, right? And it's also written that esters metabolized by all that. So now let us understand how these amino esters look and why the name is given. So if you look at the structure of this is what the amino esters. So what is ester? Ester is COC bond. So if you look at this is a carbon, you can see this is oxygen, you can see carbon. It has got a COC bond, so it is known as ester, and it has an amine. So you can see this amine. So that is the reason amino ester. So this is what you have to understand regarding these amino esters. So when I look at the structure, when I look at the structure of the examples which have come under this amino esters, those are, that is cocaine and procaine. So now let us understand how this procaine and cocaine looks. So let's go with the first structure of cocaine. If you see the structure of the cocaine, as I promised you earlier, it is an amino esters. You can see it looks like this. So you can see this. This is ester bond. You can see this amine group. So this is what the structure of cocaine is. So when you look at the structure of this procaine, you can see the same structure. You can see this. You can see the ester bond. You can see the amine. So that is the reason we have considered them as amino esters. Consider them as amino esters. So now let's see what happens at this point of view. The moment I give procaine or cocaine, right? So let me go with the first one here. So the moment I give this amino esters, right? And remember that amino esters are metabolized by the plasma pseudocholine, right? You know have a concept that in the plasma you have got a pseudocholinesterase that can metabolize some of the drugs. So these esters, this ester bond, this one is metabolized by the plasma pseudocholinesterase, right? It is metabolized plasma pseudocholinesterase, except cocaine which is metabolized in the liver. So this is what you have to understand, that all the amines, in the esters are metabolized by this plasma pseudocholinesterase except this cocaine. So cocaine, it is which is metabolized by the liver. So you have to understand the basic concept of this, right? So let's see the next point. So how do you remember this cocaine and the liver? So you can just remember coke, and it's a long coke, L for liver, so somehow you remember. So next we have got esters. Esters are unstable solutions, right? They are unstable solution. They are metabolized to para amino benzoic acid, that is PABA, right, which is responsible for the high incidence of allergic reaction. So avoid in the persons who have got this allergy to this PABA, right? So now let us understand what is it trying to tell. So when I look at the structure of this, so you can see this is an amino esters. So you can see this is an amine, the same thing, but I drew it like this. So you can see the same benzene group, you can see this NH2, the same equation I wrote it here. So when this metabolizes, right, it forms a compound. If you look at this compound is known as para-amino benzoic acid. So why it is known as para-amino? If you look at the location of this amine and the COH group, it is opposite, so it is para. Why it is amine? Because it's amino group. Why it is oic acid? Because COH is used, this is carboxylic acid, so COH is used, so it is total, we call it as para means location, amino, benzoic, it is an acid. So this, if you look at this, once this para-amino benzoic acid is located, so or this aggregated in the body, So which is responsible for the high incidence of allergic reaction. This can show allergic reaction. So what can be the allergic reaction? There can be dryness, itching. So that are the common thing. It can affect the cells of the, then they can be released with histamine. All that nonsense goes on. So this is what you have to understand, and this is all it's written in our notes. So that is the reason you are not supposed to give this local anesthesia. You are not supposed to give this amino esters which can metabolize to this para amino benzoic acid, right? Metabolize para amino benzoic acid. You're not supposed to give this person who are sensitive to this or allergy to this para amino benzoic acid. So this is all you have to understand regarding this. So the allergies and paba, okay, so that is all you have to understand. So we already spoke about that cocaine, it metabolizes in the liver. So if you look at the structure here, so this is the cocaine. Whenever it goes into liver, it can forms two, that is benzoyl nestis cocaethylene. So these are not that important, but remember that this cocaine metabolism, in this process of the metabolism of cocaine, you don't see para-aminobenzoic acid because you have found these other two. So you have just remember that, you can just find out. So once these are the important things you have to understand regarding the benzoic acid. These are the basics you have to understand to remember these facts. So this is what you have to understand. Let's understand the next concept here. The next concept to understand here is you have got other type of drugs. So other type of local anesthesia structures, you can see this is amino amides. So if you see the structure of this, this is an amino amide. You got a two nitrogen atoms here, okay, fine. So this structure, this is how the amino amide looks. So it contains, you have got examples under this. It consists of lignocaine and bupivacaine. So if I want to show you the structure of this, it should look similar to this. It should have two nitrogens. It should have all the structure, right, similar to that. So let's understand the first structure of lignocaine here. If you look at the lignocaine, as I promised you, it has got a two nitrogen atoms. So you can see this is an amino amide. This is amino amide. So what is this? This is a bupivacaine. If you look at the structure of this, you have got a two nitrogen. So this is why we call it as amino amide. So these lignocaine and the bupivacaine, they come under this amino amides. So these are the basic concept you have to understand to remember the facts which are written under this local anesthesia structure, right? So now it's time to understand few concepts regarding this amino amides. So I have already told you the structure of amino acids which have got two nitrogen atoms. So right now we just look at the structure here. When I look at the metabolism, they metabolize in the liver. As I told you, amino esters, they metabolize by pseudocholinesterase except the cocaine. These amino amides, they primarily metabolize in the liver, right? So once there is metabolized, it's not like something with amino esters where they form this para-aminobenzoic acid. They form a stable solution. So I've got a less incidence of allergic reaction. This have got less incidence of allergic reaction. So this is what you have to understand, the concepts of these local anesthesia of the amino amides. So under this local anesthesia, you got something here. The somethings are the local anesthesia can be short acting, that means they act within short time, for a short time. They can be intermediate acting, can be a long acting. So let me read what's written in our notes. It's written that if you look at the structure of this, you got something, right? So what are those are? So you can see under the short acting, you have got what is chlorprocaine, and next you have got procaine. Then intermediate you have got acting there cocaine and lidocaine. Next you have got long acting, it is bupivacaine, ropivacaine and dubivacaine. So how do you remember that? So we being a doctors, we are long enough, so we can live for a long time because we concentrate on food. So you can just remember like that. So Dr. B, it is Dr. B. So what is D? D is dubicanine. What is R? R is ropivacaine. What is B? B is bupivacaine. B is bupivacaine. What is R? R is ropivacaine, and D is dubicaine. So these are the drugs which acts for the longer time. So next you have got something known as intermediate acting. If you look at this structure, you have got cocaine and the lidocaine. How do you remember this? When your internship, people call you, right? PGs call you to work. So this is what you can understand. CAL, call, inter, C for cocaine, L is lidocaine, A is acting, right? So you can see lidocaine, you can see cocaine, and this is what the acting is. So next you have got a short acting. Under the short acting, if you look at the short acting here, So short acting includes these. What is this? Chlorprocaine, and you can remember procaine. How do you remember this? So you can remember this when I take the first five letters of this chlorprocaine, it looks like CHIL, run children, right? The first two letters CHILDREN, in the first two letters, in these letters are CSCH, so they are children are short age, so short acting. So what is procaine? P for pediatrics. P for pediatrics. Even they are short acting. So this is how you can just remember the local anesthesia. We already spoke about the classification of the local anesthesia based on the structure. We already spoke about the classification of local anesthesia based on the acting. That we have got a long acting, intermediate acting, short acting. Where long acting is Dr. B, and intermediate acting is called, and the short acting is CP, that is children and the pediatric. So these are the basic concept you have to understand. And the next thing you have to understand is we got few topically acting local anesthesia, right? So let's see what are the topically acting local anesthesia. We can act topically on the skin. So what can we do that? So topical acting are, the first thing you have to understand is prilocaine. Next you have got lignocaine, then you have got tetracaine, then you have got dibucaine, then you have got cocaine, then you have got benzocaine. So how do you remember this? There's a small story. Just remember if you feel like remembering, otherwise you can just leave it. So let's see the first one. How do we remember this? I got it, 4 Benz cards. So 4 Benz cards. What is 4? 4 is tetracaine. What is Benz? It is benzocaine. So the moment 4 people have they have got down, right, and they have book, and inside book what do have is they have cocaine, right? They have cocaine. So book is known as bucaine. So we finished with this. They have cocaine inside the book, so it is cocaine. So you have got a benzocaine, you got a cocaine, then you have got dipocaine, then you have tetrocaine. You know the basic concept of lignocaine. They got a basic concept of lignocaine. So next you have got prilocaine. So just remember that after they took the cocaine, they washed hands with the pril, so prilocaine. So this is how you can remember this. So this is how you can remember the topically acting local anesthesia are. So now let us understand a few basic concepts regarding these drugs acting actually. So let's see the first one. So we are gonna deal with the pharmacokinetics actually. So pharmacokinetics of local anesthesia. So what is pharmacokinetics? Pharmacokinetics are a branch of pharmacology concerned with the movement of drugs within the body. That means we are gonna deal how the drug is moving inside the body. So how fast it is moving, or are there any factors which are responsible for the movement of the drugs in the body. So let's go with the first one, that is absorption. So we are gonna deal how, in what cases, what are the factors which are influencing the absorption of local anesthesia. So let me take with the first concept. The first concept is the absorption of the local anesthesia depend on the site of injection. More vascular the site, the faster the absorption. So lead to shorter duration of action. So what is it trying to tell? Suppose if I inject the area, right, which has got a good vascular supply. So example IV, right. So if the site of injection has got vascular, right, the site of injection, more vascular the site, the faster the absorption, lead to shorter duration of action. So shorter duration of action, because it is absorbing fast. If absorbing fast, it's going fast into the nerves and showing the effect. So this is what you have to understand. The absorption of the local anesthesia depend on the site of injection, right. Site of injection, the first thing we are going to deal with, if they have vascular site, more absorption, less duration of action. So this is what you have to understand. And the next thing you have to understand, so whenever I give local anesthesia, the different position, so different position have got a different peak of concentration. So example, peak concentration of plasma after single shot of local anesthesia. So when I look local anesthesia, when I give a single shot at the intercostal or epidural or lumbar puncture, so not lumbar puncture, epidural, then brachial plexus, when I give at this area, I am going to tell you now in what, suppose if I give all the time shots at this area in the same time, suppose if we are not supposed to give, if we give, we are going to deal a peak concentration of plasma after single shot of local anesthesia. So you have to understand the first thing, IV has gotten more concentration in the plasma after a single shot. Then comes the tracheal, then comes the intrapleural. So what is intrapleural? Intervenes inside the pleural cavity. Next you have got intercostal, then comes the caudal, then comes the epidural, then comes the lumbar epidural, that is lumbar epidural. Next comes the brachial plexus. How do we remember this? So first is the IV, you can just see the IV drops, then it's falling into the trachea, second is the trachea, and third comes the intrapleural. This is intrapleural. Then fourth comes the, you can see these are the intercostal, you can see the fourth is the space, intercostal space. So 1, 2, 3, 4. Then let's see, the next one you have to understand here is caudal. Fifth is caudal, right? So caudal epidural, then you have, then comes the lumbar epidural, then you can see this at the last, you can see the brachial plexus, B for bite, right? So you have got, you can understand that this is all it's written, that these are the levels of, these are the peaks you have to understand here. And the next thing you have to understand here is now the profile of a drug pharmacology. That means you have to understand that so it all depends on the intermediate acting, long acting, different drugs we already spoke, which one is in long acting, Dr. B, all that. So it also depends on them also. It also depends on pharmacological profile. So whether the drug is intermediate acting or the long acting. If it is a long acting, it acts for a long time. So it all depends on that also. So this is what you have to understand regarding this. What is epidural? Epidural is, you can see this is an vertebral column where you can see this is an epidural space, this is a dura mater, and this is arachnoid, this subarachnoid matter. So this is what you have to understand regarding this pharmacokinetics of this. And the next thing you have to understand, and this absorption of the local anesthesia also depends on the dose. So let's see, if it has got a high dose, it absorbs more, right? So slow absorbs is slow when it is a short dose. So it all depends on the dose also. So high dose and low dose also absorbs, tells us that. So other thing you have to understand that, so addition of vasoconstriction lead to longer duration of action. So what is it trying to tell? Suppose if this is skin here, I want to operate at this point, I want to take an incision, so I have given a local anesthesia along with the vasoconstriction. One of the vasoconstrictor is adrenaline. Since adrenaline acts on the alpha 1 receptors, it can block say example, right now there is an adrenaline, there is a local anesthesia here. What does this adrenaline does? They act on the alpha 1 receptors and they constrict the blood vessels. So you got a nerve at this aspect. So the constriction of the blood vessels in turn helping the concentration of the local anesthesia more in the blood, so that it can diffuse, it can go and act on the nerve. So this is what you have to understand, that addition of vasoconstriction, right? Addition of vasoconstriction, that decreases the flow of blood because of the vasoconstriction, in turn increases duration of action. So you can see the duration of action of this, they're gonna produce it slowly, then you can see the duration of action. So this is what you have to understand regarding the addition of vasoconstriction. And the other thing you have to understand, that whenever we give local anesthesia, right? So you can observe these are the myelin sheets, and at this point this is what the road of Ranvier is. So let's see what happens at this road of Ranvier. What is the action of this local anesthesia? So when I take this section out, so you can look, let me take the section out. So let me take a small section of the road of Ranvier and let me draw it in a separate, and this is what you can see. This is the part of node of Ranvier here, where you have gotten receptors. These are the receptors for the sodium. You can see that whenever I stimulate that, normally whenever I stimulate there is entry of sodium, you can see the depolarization. So what happens with the lignocane? If you look at the lignocane, we'll give lignocane in the form of this RNH. So what happens here is, this is the nerve here, this is the part of nerve, this is this is a nerve center. Actually this is an outer aspect of the nerve, this is the inner aspect of nerve. So let's see what are we gonna do here. So this is what we gave lignocane. It splits into RN, right? What is R? R is nothing but CH2. I already spoke about the structure of this lignocane or the local anesthesia, where it has got a nitrogen, hydrogen, all that. So that is what it's telling us. The moment I give, right, the moment I give lignocane, you have to understand that this space has got an alkaline medium. This space has gotten a good alkaline medium. So in the alkaline medium, what happens in the alkaline medium is, so you can observe this, it splits into, what does it do? It splits into Rn plus H plus. then this Rn, what is that Rn? Rn is nothing but it can be alkyl group with a one of the nitrogen, and this is what the non-ionizing. This is non-ionized because you don't have any H plus or minus, and this non-ionized can diffuse into the nerve, So the soon after it diffuses into the nerve, you can see this Rn is binding with H plus proton and it's forming RNH plus, and this all takes place, this equation takes place intra nerve, right, where it has got a look acidic, right, so acidic pH. So in the acidic pH you can see this ionized anesthesia, local anesthesia is formed. So right now the moment you gave RNH, it has split into Rn plus H plus. Rn being non-ionized, it diffused into the neuron, then this Rn binds with this H plus and forms RNH. So if you look at this aspect, this is the step which is happening at the alkaline medium, and this is the step which is happening in the acidic medium. Say example, right now RNH is present in the nerve, so what does it do? It goes and binds to the receptors which where the sodium receptors, and it blocks the entry of sodium, so there is no depolarization, and you can observe that the what in the sense you can see the nerve goes into anesthetic condition. So this is the basic concept you have to understand regarding the structure or the action of the local anesthesia on the sodium receptors. As you know that it's gonna act inside, right, so it's gonna act inside actually. So this is what you have to understand, the basic concept, and that is all it's written. And the next thing you have to understand here is pH at which 50 what is pKa? PKa is an pH at which 50% of drug ionized are in the state of ionized and 50% are non-ionized. So in that condition we call it as pKa, right? So the next thing you have to understand here is, why are we gonna deal with this pKa? Because drugs having pK value close to the physiological pH are more fast acting than the others. So if what is the physiological pH? The physiological pH is 7.5. The physiological pH is 7.5. So if the any of the drug has got close with this 7.5, they are actually like they are acting fast. So example, if I give two example, if you look at the lignocaine here, it has got an pK value of 7.8, and bupivacaine it has got 8.1. So if you look at this, the pK value of lignocaine is 7.8 and the bupivacaine is 8.1. Which is more closer to this normal physiological value? It is a lignocaine which is 7.8 is more closer to the 7.35. So that is the reason this has got most faster activity than the other drugs. So they are more fast acting than the other drugs. So because of close relation of pKa with this pH. So this is all you have to understand regarding this. And the next thing you have to understand that there is an example. So example, right now we expect that what happens here is, I already told you, in the alkaline medium RNH it splits into Rn plus H plus, then Rn diffuse into the neuron. So what happens in the infected tissue? In the infected tissue, if you look at the pH of the infected tissue, now the pH is not alkaline, it is acidic. So it is acidic. So if it is in the acidic media, the lignocaine, the drug is in ionized form, So when it is ionized form, it cannot diffuse into the nerve. If it cannot diffuse into the nerve, it cannot act on the sodium receptors. If it cannot act on the sodium receptors, it cannot block the sodium receptors. So if it cannot block the sodium receptor, there is entry of sodium and there is a pain. But right now, that is the reason they do not, that is the reason local anesthesia ionized in infective tissue which failed to penetrate axon membrane. Hence local anesthesia should not be used in infective tissue. That is the reason you are not supposed to use this in infective tissue, because of the acidic environment of the infective tissue that can actually reduce the action of this lignocaine. So now let us understand with this other aspect. So other aspect is regarding, you have to understand what is the differential sensory blockage actually. So what is differential sensory sensory blockage? And it is shown by drugs like bupivacaine and ropivacaine also. So it is shown by bupivacaine and ropivacaine. So what happens here is, at low concentration, right, when I give bupivacaine at low concentration, it causes sensory block. So if I give bupivacaine at high concentration to the person, it blocks both sensory and motor. So example, if I give example of this, let's say bupivacaine, right, it has got 0.125% of concentration. When I give to the patient, it blocks only sensory only. But when I give bit higher, that is 0.5%, it blocks both sensory and motor block. So can I use, since it is blocking only sensory, can I use this mechanism in the labor so that there is reduced pain? Yes, there is labor anesthesia. We are gonna give this bupivacaine, right? So these are the basic concept you have to understand here. So the other thing you have to understand that this aspect is, we already spoke about the differential, we already spoke about the pharmacokinetics. So in the next session we'll be dealing with this, the other parts of this. So in the next session we'll be doing. Thank you guys.